Good afternoon, everyone, and welcome to the 7th in our series of QI Connect webinars. My name is Brian Robson. I'm the Executive Clinical Director here at Healthcare Improvement Scotland. We're delighted to have you join this series of calls. Now, we're more than halfway through our series, and this series came from a request from national clinical leads who work with us here in Healthcare Improvement Scotland to help them connect in as frontline clinicians interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded so that they could be accessed after the event itself. And what we've done is we've set up this series throughout 2014 that's been very well received. I'll tell you a little bit more about that in a moment, but I'm going to hand over to Jennifer Graham, our clinical coordinator here at Healthcare Improvement Scotland, to take you through some of the aspects of WebEx. Jennifer.
Thanks, Brian, and welcome to everyone on the call. So we're really keen to make this a really interactive session to maximise how much learning you get out of our work. Just a couple of housekeeping slides just to get started. If you could use the chat function, I'm going to say a little more about that in a moment, to ask questions and get involved in the discussions. And if you are having any technical difficulties, if you could just message the host via the WebEx chat function in the bottom right-hand side, or call, there's a mobile number there for assistance, and someone will get back to you. And WebEx orientation. So on the right-hand side of the screen, you should be able to see a list of everyone who has joined the call. If you wish to make a comment or join the conversation in the chat box, please select all participants from the drop-down list circulated in red on this slide, type your message and then send. And we really encourage you to ask questions and make comments as the discussion unfolds. So here's the fun interactive bit. So where are you joining us from? If on the toolbar just above there, there's a blue arrow to the top left-hand side of your screen. If you could just all click on that, and then just click on the map where you're linking in from, and that just gives us a real feel for where everyone's dialing in.
Good to see Ross joining us from the centre of Russia. Excellent.
Okay. So that's great. So I'll just hand back over to Brian now, just to tell you a little bit more about some of the organisations that are linking into the session.
Great. Thanks very much, Jennifer, and thanks to you all for joining us. Now, when we started this series, we had one slide, and that one slide told us everyone that was joining in. We're now looking at 4 slides. So this is the first one. We're absolutely delighted to have many of these organisations join us now for the 7th time. Jennifer, next slide, please.
Okay.
We also have an increasing number, more of our colleagues have joined us in the previous calls, and we're absolutely delighted to welcome them to the call also. Thanks, Jennifer. However, we're absolutely delighted that the series, and this call in particular, has really appealed to many of the universities and learning organisations, both here in the United Kingdom and further afield. And a big shout out to the 11 universities that are now joining the call. And in particular, we're absolutely delighted that this is a first-time call for Strathclyde University here in Scotland, the University of Leicester, the University of Edinburgh and the east side of Scotland, and also to the Nordic School of Public Health. Welcome to you. We also have the series on this slide. We have Futurum from the Academy of Improvement in Jönköping in Sweden, St Andrew's Hospice, the LA County Department of Health Services, the NMAP Allied Health Professions Research Unit, and ProQualis. So welcome to all of those new organisations. It's absolutely super to have you on board. And we are delighted that we're now reaching 40 countries. We announced 40 countries the last time that we came onto the call, so we haven't increased that number, but we're delighted to be setting a stretch aim. We're looking for 50 countries to join this series before the end of 2014. So if you've got pals in other countries that you want to connect us in with through this series, please let Jennifer or Carmen know. Thanks, Jennifer. And again, we're delighted to have ISQA have the QI Connect series as an approved resource within the ISQA Fellowship Programme, and they've helped greatly in our international reach. Just to remind everyone that the call is recorded, as are the comments and chat, and it will be available, and Carmen will be in touch after the call to let you know how to access that. And that will allow you to use the call freely for further learning after the event. And of course, Twitter, we really want you to be tweeting about what you're hearing on the call and really growing our international Twitter activity. And this is just to let you know a little bit about the team that bring this to you. We have Jennifer Graham as the clinical coordinator. We have Carmen, who runs all the certification and administration. And we also have Ross Stewart, who's been working with you all to get you signed up for this event and organising future events. I'm delighted to say that we mentioned earlier that this series came from an idea from our national clinical leads. And one of the things that they have done in earlier calls has been to ask a question of the speaker. And today we're delighted that Karen Ritchie, our very own Head of Knowledge and Information here at Healthcare Improvement Scotland, is going to be asking the first question. We'll look forward to welcoming Karen a bit later on in the call. However, that brings us to today's event. We're absolutely delighted to have Professor Nick Barber join us on the QI Connect series. Nick is the Director of Research at the Health Foundation, which is a charity dedicated to improving healthcare. Nick is a pharmacist by background, and he's been running hospital pharmacies through his career, and for 20 years was a Professor of Pharmacy Practice at the University College London School of Pharmacy. Nick has been the Vice President of the Royal Pharmaceutical Society, and he has a starring role in a BBC Two series called The Victorian Pharmacy, which really brought to life some of the history behind the medicines that we use nowadays. But Nick is, as the Director of Research at the Health Foundation, has been a very close ally with us in Scotland, and we're absolutely delighted to have him join the call. Good afternoon, Nick.
Good afternoon, Brian, and welcome everybody. Welcome to my office in sunny Covent Garden in London. Thank you for inviting me for this. I feel privileged to join this impressive panel of speakers. And I suggested this topic because I was confused about the many challenges which there are in working with evaluating improvements. And I'm also just going to pause because my screen's just gone blank. By the miracle of digital technology, there we are, I've got it back. So when we do research at the whole research team at the Health Foundation have commissioned a lot of evaluations and been close to them, and we continue to try and work out what's the best way to do them. Now, I know you as an audience are international, you have a variety of backgrounds, so I'm going to start with some of the basics of evaluation, and then I'm going to take you on to some of the large evaluations which I've been involved in and explain them, which is probably therapy really as much as anything on my part, and give you my experiences there, and then end by telling you where my thinking is at the moment. We're going to have a real push on evaluation next year at the Health Foundation, and really thinking about it and trying to get a better way of understanding what works and doesn't work, because at the moment there's a lot of randomized controlled trials showing no effect on a whole series of interventions, and we wonder whether that's the intervention or whether that's the methodology that's part of the problem. I should mention that Laura Leviton, who's the doyen of evaluation at the Robert Woods Johnson Foundation, who's been a head of the National Association of Evaluation in the USA, has been involved in over 100 evaluations, has been someone I've often talked things through, and in celebration of that, I've stolen some of her slides and are using them here. So let's go on to see what evaluation is. So here are three different definitions of evaluation, which come from different sources, referenced at the bottom. The word value in evaluation is the clue, really. It's a bit of a difference to just doing research, where you get the answer or a significant difference between things. We're much more involved in the merit, the worth, the value, surprise, surprise, of something, not just of the data. And it's systematic. The second definition brings that out, and normally data driven. But it's also fits a purpose, if you like. We have to use the methodologies which suit the needs of the study. What are we trying to show? And what would be the best methods to use that? And I think this third one brings out one of the important things for me, which is decision making. I think we sometimes lose track of that. What's the point of an evaluation? It's so we can make a decision about what we do. Do we adopt this? Do we abandon it? Do we tweak it this way or that way? And it allows us to influence others and to try and make the world a better place, which, after all, is what we should all be trying to do. This next slide shows you some evaluation questions, and I'm just going to be quiet for a few seconds to let you read through that. Now we're talking about evaluating improvements here, so let's just start with a common problem that there is with improvement. And I have just seen this so much. This is a slide from I've stolen from Mary Dixon Woods at Leicester. So often, I was one of the first professors of pharmacy practice, and people really wanted to show pharmacists could make a difference clinically. And they'd get some money, and then they'd do a large randomized control trial in which they'd say the patient will meet the pharmacist to discuss their medicines, and then they'd have some endpoint, and lo and behold, absolutely nothing happened. And it was because there was no logical thinking about what was going on. Nobody was saying which aspects of prescribing are we supposed to be changing in some way, the costs, the side effects, the satisfaction, the adherence. And if those are the things, which one of those are we doing, and how would the pharmacist make that happen? By what mechanism? And how would we know? Would we be able to measure that? So some people, and it's quite common, surprisingly common, have ideas for improvement, and really it's based on something like a whim or a feel, and it's not explicated, it's not explained as to what's going on. And I think the evaluator has an important role here. We're not just passive observers. We don't rock up to some event and say, oh, look what's happening. God, they're making a mess of that, aren't they? What we've got to do is get involved in the same way when you're doing a research protocol and you get a statistician involved. The first time you do it, you're probably a bit shocked that they then start looking at your whole research design. It's the same with the evaluator. We need to know what's going on. We need to get involved, because it may well be that the evaluation is going to be a complete failure because the project's just not going to work, and in which case you should walk away. So this is one of the challenge for evaluators, and there's an idea called evaluability assessment, which I'll go on to now. So we can look at the different types of evaluation and the relationship with evaluability. So I'm sure you're familiar with summative evaluations and formative evaluations. Summative summates things, it's the final sort of judgment on the thing, and formative is information which you're using to help shape what's happening and to help change the intervention or whatever's happening around it. These words come from education originally, where they sound quite logical. You're forming the student in some way, and then you're getting a summation of where they are at the end. And people tend to rush into summative evaluation, as I illustrated with the previous slide. And it's just a waste of money. And actually, I think a lot of good ideas are killed while still in the cradle by rushing in to do this. And of course, it's very expensive to do these things quite often, and so it's just an inefficient waste of money. So good outcome studies are the culmination of careful work, starting with formative evaluation, and I'll elaborate on this towards the end, or ideally, evaluability assessment. So let's have a look at that. So here we see some steps in evaluability assessment. It says you get involved with the end users first. What do they want? What do they want to know? And different end users may want different things. If you're looking at the introduction of electronic health record into a hospital, then basically the finance director wants something completely different to the medical director. And you have to work out whether you've got to please both of those or one of them. So involve the end users. And then you can look at the scope of the project, look at their documents, consult with stakeholders, and can you get agreement on the goals that you're trying to do? If not, and it may be the case, then you may have to iterate round, you may have to talk with people about why you're unhappy, and come again. And eventually, as you see that sort of hexagon saying stop on the right, you may just have to walk away. If you can agree the goals, then the next thing is it'd be nice to know how things are going to work. So you can create or revise a logic model and or a theory of change, and I'll expand on those in the next couple of slides. Can you agree on the model? Yes, then check out with the staff themselves whether what you've been told seems realistic or not. Quite often the people at the top of these things have grand ideas that are not in touch with the reality on the ground. And then if that's the case, you have the basis for an evaluation. What's the logic model? That was one of the things I mentioned. Well, here's a typical one. Given certain resources and inputs, then you'd be able to do certain activities. If you can do those, then you expect the following outputs, and those should lead to outcomes, and those should lead to impacts. There are various sources of this. There's a plethora of these on the web if you want to look at them. And this is shown as very linear and rational, although, as ever in life, they're often not, and perhaps one which is a bit fuzzy and iterative is more realistic. A bit about theory. People get frightened about theory, and yet we all use theories, and that's why it's best to be explicit about what those theories are. You have a theory about what happens when you go into Starbucks and ask for a cappuccino, and you're normally happy that it works out. It's a theory. It may not be published in Nature, but it's a theory you're working with. And you have theories as to how people behave, what they'll respond to, what the problems are with systems, all these sorts of things. And you can have theories in a whole range of sizes. Big ones can be like how people perceive probability and risk and things like that. So Kahneman and Tversky, for example, talk about this. These are the people who influence the nudge agenda, where the rationality of economics was brought face to face with the reality of psychology to produce nudge, behavioral economics. We have middle-range theories like the diffusion of innovations. How do people pick up ideas and transmit them to others? And Rogers' theory is the one which you probably know without knowing it. It's the one with the early adopters and the laggards and those sorts of things. And it's actually based on social networks. And then one of my favorites at the moment, and it's still what I'm playing around with, is what I call the backward theory, the normalization process theory by Karl May and others. And the reason why I call it the backwards theory is that name probably means nothing to you, but if I tell you it's a theory about how processes become normalized, why is it that we have a new way of working with a new technology or a new way of running a clinic or something, you'll see how useful it is. And you just Google NPT and Karl May and you'll find their website. And then some of these theories are quite straightforward and not gracing the literature. If this happens, then that, and therefore we'd expect the following. Here's an example of a small theory with a bit of duct tape on a door, just the left of the handle and below it. You can see it stuck there. Stops the noisy door being closed, which means that the patient gets a better night's sleep every time somebody goes in and out. Now, from evaluability assessment, which we've been looking at, let's look quickly at some aspects of quantitative and qualitative evaluations before going on to some case studies. Now, of course, we could spend a whole master's degree on this quantitative issue. So I'll try and simplify it, excuse the bits I miss out. But at its heart, we're going to measure stuff. It might be very basic measurements, whether there's someone in the room or not, how many patients go through the system, or it could be far more complicated. Measuring is actually quite a tricky thing, and if you can get people to help or check your measures with other people or talk about what you're thinking of doing when doing some implementation, then that's really important. And ideally, as part of the implementation, you'd be measuring stuff which can be used in the evaluation as well. And I've got a lovely example of that, which is that we're trying, actually using behavioral economics to improve the number of attenders at clinics. And I think it was Bart's Hospital. And they routinely collect do not attend records for each clinic. So they tried different text messages. You know, if you fail to make this appointment, then it costs the NHS £20 or things like this. And they tried 6 different ones. They randomized the patients they sent it to and the different messages, and then they just compared the did not attend records from their routine data at the end of a couple of months. And they found a 20% difference in attendance between the best and the worst message. So there's a way in which I thought that was a really elegant, simple evaluation using existing measurements. There are often measures out there for the things you want to do. We'd like measures to be valid, i.e. that they measure what they say they are, and reliable, that they give the same answer every time. And a bit of literature searching can sometimes help you find that, or ringing up an academic department if you're not familiar with those things yourself. And if we measure stuff, what are we going to do with those measurements? We're going to have more than one, and we're going to compare them in some way. So we can compare them, first of all, with the literature, for example. That can be misleading for other countries. All sorts of different practices may be there. But you can, it's also really instructive to just compare them to other groups. You know, when I was running a hospital pharmacy, we'd compare our waiting times with the other chief pharmacists in the region. And if yours was pretty good, and it seems reasonable to patients, then maybe you just wouldn't do improvement in that area. There's other areas which need improvement. So it's a really good way of finding out what's going on. One of the problems is that sometimes people improve or try and improve things which are already pretty good. We found this with the Safer Patients initiative, which I was part of the evaluation team of that, where some of the metrics we were measuring were well over 90% compliance with good practice. So the chance to improve was negligible, really. So it's a good first place to see where you are now and whether you really have a problem or not. Then you can measure yourself over time. This is a natural thing to do, the same way you look at the height of your children and mark those up on a door or a scale, or you might follow your own weight. And in areas like pharmacy, when I used to run sterile production units and so on, we would have routine monitoring of things like air pressure, fridge temperatures, and things like this. And you may have an intervention, you may measure something before, and then, surprise, surprise, you do your intervention and measure it afterwards. You may measure things continuously over time. You could do that as a quality control measure, as I was talking about in a pharmacy. You don't want your certain things to drop below a certain level. You may want to follow the number of days that the wards being free of C. diff or things like this. And if you measure them over time, you may then try and change them if you're not happy with the standards. And in that case, there's a whole plethora of techniques called statistical process control, SPC, which can be used to follow these over time and see when your changes are really making a difference or they're just a bit of a random variation. The problem with doing things over time is we don't know if everything else is changing in the same way over time. And this has dogged several large studies of improvements. So the Health Foundation's Safer Patients initiative, when we evaluated that, we found, yes, in the trial sites, mortality decreased, and surprise, surprise, exactly the same thing happened at the control sites as well. And so you never quite have the same heft behind you if you don't have some sort of control group. So it's worth thinking out whether you can have some another group who you can use as a parallel control. And then people get into whether there's bias or not there, and you can go on to randomized controls. I gave you the example of the text messages, which is quite an easy one. And you can then go into the whole step wedge and all sorts of other trial designs, which are very advanced, and you need statisticians to help you. So let's have a look at qualitative evaluation. Well, with numbers, you often don't understand what's going on. And I think understanding is one of the most undervalued concepts in science and in improvement. Often people will leap in to try and change a system, introduce a new piece of technology without understanding what the current system is, what its level of performance is, why it performs as it does, and how it could be improved. So qualitative evaluation, often before you start an intervention, can be really useful. But even if your evaluation, the summative evaluation, may show no significant difference, this gives you a whole load of interesting information. I'll demonstrate that in a minute with the Matching Michigan study. You can also use it to generate hypotheses. I did this in the 90s when I was part of a group looking at the doctor-patient communication, tape recording consultations, interviewing patients, and came up with an understanding of how problems that patients had, or a hypothesis that patients often just lacked information and understanding and didn't take their drugs properly afterwards, and that ultimately led to a new piece of work, and ultimately we showed a system to solve this, and we've just finished it's become a national funded system in the NHS in England. It helps explain your findings to others and connect with them. It helps you to tell stories. We're driven by stories. We're naturally storytellers. And we need to find stories to go with the dry data. And it can also help test your theory or develop your theory as well. There's a range of techniques which many of you will know: observation, interview. Often these are sort of grouped together as ethnographic techniques, which are sort of interpretative field work. You watch what's going on, you talk to people, you chat in the corridors, you go and have lunch with them, you look at minutes of meetings, documents, things like this, and also methods such as focus groups and so on. I would say that good qualitative evaluation is quite a skill, and it pays to work with people who really understand it. Now, we've done the two types, and often it's best to mix them together, which virtually all my research has had a mixture of these things. And as this one's from Laura Leviton, as she said, all data is flawed, but it's not all got the same flaws. So put it together to tell the whole story. So we've had a quick look at qualitative and quantitative evaluations. Before that, we looked at evaluability. Now let's look at some case studies. The first one I'm going to whiz through is about Matching Michigan, as it was called. We funded a study called the Lining Up Study. I'll give you a reference to it at the end, and I'll explain what Matching Michigan is. So it would seem sensible that when someone in another country does something which works in a lot of hospitals and is really effective, we should copy it. And lo and behold, this is what we did. So the Michigan Keystone project, in over 100 intensive care units in Michigan, reduced central line infection rates by over 80%, remarkable effect. And this was a battery of tools which had to be used together, such as hand hygiene, chlorhexidine, and the other things you see up there on the screen. Some of the reasons, some of the important aspects aspects of it in the US were it was voluntary, although chief execs of hospitals sort of felt a bit out of it if theirs wasn't in it. Some people believed that these things were unavoidable. It challenged that and made them realize that they were amenable, you could improve them. There was lots of hearts and minds stuff. And you'll see that these two things of the data and the storytelling, by the way, is, of course, standard in improvement. The old phrase, no data without a story and no story without data, really just goes back to the previous couple of slides where we were looking at a mixture of qualitative and quantitative. Now, this was so absolutely wonderful that the NHS in England, when they were producing a report on high-quality care for all and the way forward, said that they'd follow what was done with this remarkably successful Michigan initiative. So the National Patient Safety Agency, now defunct in England, invited ICUs to participate. There were some differences, the training and some wider collection of data. It's interesting to note that actually they found that the infection rates were half those of Michigan. This isn't unusual. We've come across this in other areas where you take things from another country. I mean, we find that the effect size of electronic prescribing in hospitals is about half in the UK what it is in the USA. The live births in the UK is about much better than that in a lot of states in the USA. It depends which country you're in, which state, and all these sorts of things. So it was a bit of a... So there's less chance for improvement, but still, they got stuck in. And the Health Foundation funded a study of this to see what happened, and interviewed the leaders, ethnographic study at 19 sites, and did a long-term analysis, as well as a separate study was done, a quantitative study of the data across all the ICUs. They found that there was an improvement, down to the same level as Michigan. However, it wasn't significantly different to sites which weren't involved in the scheme, and there was already a trend of movement before it was introduced. So it was never intended to be exactly the same as the Michigan Keystone thing, and the technical bits could be done, but it's actually the social and behavioural parts of it that were important. And some places really grasped it and used it. I mean, one ICU said it was absolutely transformed by using this. It opened their eyes, it gave them way forward, it made a big improvement. 5 improved their rates, but were not totally wowed by it. And 11 sites, there was a low impact on their behaviour. And you can see, you don't have to know the details of this at the bottom, but you can see there's a mixture between the ways in which they measured infection rate and the believability, which is absolutely key. It's in normalization process theory, how much people believe what's there, and also how good the data is. And there's this lovely report from Mary Dixon Woods, who led the work. There's a much more detailed report as well on our website. But this is a nice summary. It's a really great case study of the challenges of copying an intervention from elsewhere and making it happen. Let's look at here's the current edition of BMJ Quality and Safety, and this picture on the front is represents one of the papers inside, which is research which I led on the evaluation of the electronic transmission of prescriptions between general practitioners in the UK, all general practitioners and their write prescriptions electronically, and the pharmacy. So instead of taking a piece of paper, it's sent to a mailbox and the pharmacy can draw it down at an appropriate time. And we were asked to do an evaluation of this national initiative, and it was really many facets to it. We've produced about 12 or 14 papers out of this, looking at all sorts of different aspects, but they desperately wanted something quantitative. So one of the predictions beforehand was that this would reduce the number of labeling errors made by pharmacists, because what was on the doctor's screen would go straight onto the label itself. And it was expected that this would make a difference. Luckily, my colleague, Bryony Dean Franklin at Imperial, was the only person in Britain who'd found out the previous error rate, so we worked out the sample size from this. This is not an unusual problem to have some innovation like this and find no one's done the research to tell you what the normal rate is. We followed up pharmacies. We set up a step wedge design in which we could, you measure all the pharmacies. One starts using the new system, and then a bit later the second one starts, a bit later the third one starts, until at the end all of them are using the new system. That was the theory anyway. In reality, there are all sorts of software delays. Some of the major manufacturers, one of them in particular, only produced software about 2 years after the others, so we had to wait for that to be on song. There are all sorts of practical problems about getting pharmacies and GP practices both on the same system and working together. We were told where the first site would be. We got all the research permissions, and actually the first site was about 100 miles away, so we were quite often chasing around afterwards. We had almost weekly meetings with the implementation team to find out what was going on. And what we did was, in the largest study of dispensing errors in the world, we followed every site every 3 months. Some of the sites which were going to implement the new system, it was then decided they wouldn't, so we had continued data that acted just as a big control. In the end, the step wedge design didn't work. Most of the sites that took up this system only used it for about half their prescriptions. But luckily, the statisticians we'd worked with could take care of all this in the modelling. We looked at about 16,000 items across 15 pharmacies. We found new information which nobody had known about. For example, in 13% of labels, the pharmacists had to have new information and had to change the label to improve it. And we found that the labelling errors went up from 5.4% to 7.4%. So the new system increased the number of labelling errors compared to the paper-based control. But because so few people had used the new system, we found that one site in particular, who had a strange way of dealing with all prescriptions, paper and electronic, had skewed the data, and if we did a sensitivity analysis without them, things were the same. So it shows the need for being flexible in what we were doing. We had to keep changing this as we went along, and yet try and hold on to some quantitative aspects of what was happening. And another piece of work we did, referenced on the right there, was with Liz Sheik in Edinburgh and Tony Cornford in London School of Economics and Tony Avery in Nottingham. We studied the rollout of the electronic health record in hospitals in England. That was designed as that was going to be 3 different systems in 3 parts of the country, and their second phase of implementation, which was planned 18 months ahead, they would have stuff which we could measure, information clinics, electronic prescribing, things like that. Surprise, surprise, one of the suppliers pulled out. There were arguments about another. The politicians didn't like connecting to health. The whole thing, we just ended up doing qualitative work. We couldn't get any quantitative work out of it after several years of work and probably getting on for £1 million worth of research money. And we did our reflections on that in something called Building a House on Shifting Sand, which is in that reference. Now, I'm going to have to press on. So a key question everybody asks is, does it work? Does electronic transmission of prescriptions work? Does an electronic health record work? And it's an obvious question. And it's also, in some ways, the most useless question. As I say, only has 3 problems with it. Does? Well, all we can say is it did work in 1 place or 10 places at a certain time. We don't know whether it will in the future or not. What's it? We tend to use clinical trial type approaches and designs. Now, an aspirin molecule hasn't changed in over a century and a half. We can build up knowledge about it. But electronic prescribing, there's a whole load of different systems out there. They perform differently. They're implemented differently. any of these systems, even just running clinics differently, are very different. And we can change them. If it's not working, we can make it better. It's not something where we're stuck with the molecule itself. So if something doesn't seem to be working very well, we can change it. And what does work mean? For whom does it mean work? As I said before, does it mean that it works for patients? Does it work for the finance director, the doctor in the clinic, the nurse on the ward? For whom? It may work for some and not for others. And so I've been really sort of struggling with this. It's an obvious question, and yet also so often we don't seem to be able to make definitive statements about it. And so I've come in my reading really to an understanding of more of the understanding of systems and the importance of systems in all this. And this is the Cynefin framework, as it's called. I haven't put the word up there. It's a Welsh word, and it's spelt very differently from how it's pronounced. But if you Google Dave Snowden Cognitive Edge, you will find some good videos on this. And basically, it says that we have different sorts of systems out there. We have obvious systems, if you like, going to your Starbucks or your hamburger shop. You know what the system is. You can see it. You expect it to work reliably time after time. Feeding patients on the ward should be such a system. Giving out the drugs should be in many ways. We have lots of obvious systems. And then we have complicated systems, which are much more which are much more complicated, as it says, and you need expertise to make them work properly. And if you don't have the right expertise, then they don't work that well. And then we have complex systems, and this is the world of complexity. And this is the world in which it has various characteristics of complex systems. It's not the world of science as we know it. They have many components which interact together and lead to unpredictable behavior. You could have the same starting conditions in two different hospitals and end up with quite different outcomes. They're very dependent on their history, and they're what's called non-linear, which means our routine understanding of science doesn't work. A small change in one place may lead to a big change. Small change into the system may lead to big changes in the output, and vice versa. A big change in the system may have very little effect. This is the butterfly's wing sort of story. This is where it comes from. The flap of the butterfly's wing in South America can lead to a hurricane in the Caribbean. And these systems develop emergent behaviors which are unpredictable. We don't know what's going to happen. And of course, that's a challenge to all our scientific thinking. And we as observers are part of that system. And then chaotic systems, the outcome is pretty well random. And quite often when we're developing something, we're in the complex or complicated area. And just to look at complicated and complex and help you separate them, complicated is sending a rocket to the moon or a Ferrari. You know, with the right set of equations and the right skill, you can make it happen reliably. Complex is something like bringing up a child. You know, they turn out different in spite of what you do. And a rainforest. If you cut down a tree in a rainforest or introduce a new species, then things will change in a way which you can't predict. And I found this quite useful. And then I came across, literally just a few weeks ago, this book by Michael Quinn Patton, who's one of the world leaders on thinking about evaluation. And I'm still working my way through this, but you can see he's looking at complexity, excuse me, and to enhance innovation. He's not saying it's the method for everything, but it's the method for the complex area. And in this, the evaluator is much more part of the team. They're much more involved in what's going on. Things are much less predictable. They've got to be quite skilled at a range of techniques, fast on their feet, able to change according to what's emerging from what's being tried. Quite often, because you can't predict what's going to happen in a complex system, what you often do is have lots of small trials going on. And therefore, you have to be able to assess these, whatever they're going to be, and see which seem to be working and see which to work in that system. And I think we can probably bring these together. This is actually a model based taken from ecology. Ignore the alpha and R and K and omega and that. And if you look here in the top left, you've got developmental evaluation. In that quadrant, the top left, reorganizing, exploring, creating. This is the area we're creating new things. Excuse me. It's the early area of developing things. And then as we get a better idea of what might be working, we move into an area of exploiting that and trying to improve it, piloting it at small to medium scale perhaps. And here we'd be using formative evaluations to see better what works and doesn't work, continue strengthening, getting it better to roll out and ultimately in a more mature system where we'd be having summative evaluations. And what's different is this drop down into the bottom right corner, because all systems decay or change. And this comes from an economist, Schumpeter, who talked about creative destruction, a theory we found quite useful in working with technologies and their input. You know, when you get a new technology in, it's a creative thing, but it will destroy stuff. You've got to look to what it's destroying and see whether that's a problem or not. And at some stage, that system will fail, will break down, will be changed deliberately, and then you go up to the top left into the area of complexity, where you're not quite sure, you know what's there, but you're not quite sure how it's all interacting together. The dotted line shows what's happening quickly. So these things don't last all that long, and the whole cycle may take years or decades to happen. But it gives to me a sense of flow, which I really like. So I hope that's helped you. That's where my thinking is at the moment. I am not certain it's where I'm going to be in a year's time. We're certainly going to be moving this forward, but this just sort of synergizes with a lot of my experience. There's a few extra resources at the end here, and here's what we do if you want to contact the Health Foundation. Thank you very much. Back to you, Brian.
Thank you very much indeed. That was a super run through the complexities of evaluation, and you made some of that very simple to understand, and you highlighted some of the difficulties in the complex areas. We've got a number of chat questions that I'll just formulate over the next couple of minutes, but in the meantime I'm going to hand over to Karen Ritchie, who's going to ask you the first question.
Hello Nick, thank you very much for that. I thoroughly enjoyed your presentation. So my question is that in the work that we're doing in HES, we already do a lot of small-scale evaluations, things like evaluations of the events that we run or the training sessions or our public involvement activity. And we're starting to do some, we have got some examples of external program evaluations, so summative evaluations, and we're starting to develop a process for undertaking program evaluations internally that would be more formative. But I've had questions from some of the people that we're trying to support around this about how we combine all these different elements of evaluation together into a more holistic approach. So should we be doing that? And if so, how should we be doing that?
So by a holistic approach, you mean being able to evaluate a range of things and having something which is a sort of a summary number for that. Am I understanding that correctly?
Well, not so much a summary number, but for example, one of the examples is the work of our Quality Improvement Hub. So they're undertaking a whole range of activities, and they want to know whether the hub is successful. But obviously some of the evaluations that we'll be doing will be around specific programs that will have an intervention associated with them. Some of them will be much broader activities about building capacity and capability and quality improvement skills. So, how do we bring all this together to say whether the hub is being successful or where it's being successful, or get that breadth of knowledge through the evaluation process?
Okay. Well, I think I was once working on a code of ethics, and a philosopher said to me, you only need 2 words, which are be good. And of course that works at one level, but you say, okay, how should I be good? Or I think I'm being good in this way because I'm telling the patient what to do and I know what's best, and the patient doesn't think I'm being good because they want to have their their say and their autonomy respected. So the question is, at what level do you disaggregate things that you're not comparing, apples, pears, zeppelins, and the Eiffel Tower. You're comparing similar clusters of things, and at what level is it useful to pull those together and to keep them separate? And I think, one option may be a sort of a radar diagram in which you have, if things could be produced in some sort of scales, you could have lines which go out from the center, and one of those could represent satisfaction with courses, and another could represent, successful implementations or something, and you could put scales up there. But I think it's important not to disaggregate the information, not to aggregate the information too much, but to create the arguments on their own merit. For what works and doesn't work, if we can use that term. So I think it is quite challenging, but I do think it needs to be, we shouldn't be mixing separate things. There need to be separate arguments and cases for each thing, I think.
Okay, thank you very much, Nick. I'm going to hand back to Brian, who's got some more questions.
Great, thanks for that, Karen. Thanks, Nick. We've got a number of questions here, Nick. Let me just fire off from the top and thank Ruth Roper, the lead nurse in tissue viability from NHS Lothian. Ruth is asking, do you have any tips on getting staff at the shop floor to see the benefits of measuring as they evaluate new interventions?
Well, Ruth, you ask a question which lots of people have been struggling with. They are, and this is the advantage of sitting here as a professor in an office, is I can pontificate on these things, which is a lot easier than doing them. But the key thing is win-win if you can have it. How would what they're measuring help them in some way? And I think that's an important part of it. I think stories are important as well. We talked before about no stories without data and no data without stories. I think if it can be shown that there's some local benefit there, such as some agreement from one of the bosses that there's something new comes to the ward if they achieve a certain level. It depends on your psychology of your ward, really. I mean, to some extent, I think ward managers often know their own staff and what motivates them, and it may be different things in different places. I think making things public as well helps, putting the results up at the entrance to the ward or in a prominent place where other people can see it, so it does look rather embarrassing if there are gaps in the data, but also that you can celebrate it when things are working well. It may not be in the public domain, it may be something you feel is too sensitive to put there, but it's still in places where handover happens and the clinicians are there and things like that, I think would help. So I'd say those are a small number of things. And I think belief is so important in all these things. If they believe that nothing is going to happen as a result of what's going on, then you're scuppered, really. So I think getting their belief orientated that what they're going to do is going to make a difference, to patients' lives. Maybe getting patient stories put together of how much life was better after they were, or how bad life was if they had long-term ulcers and how it affected them, all this sort of thing. It's a cornucopia of tools, tricks and techniques, I think, and you've got to work with what's available to you.
Thank you very much for that, Nick. I'm sure that Ruth was scribbling down some of that cornucopia. A question here from Scott Oliver. Scott's a renal physician, a clinical teaching fellow with NHS Lanarkshire at the moment. And Scott was really taken with your discussion around ethnographic studies and qualitative research. And he asks, what's the best way to identify the key players to involve in qualitative data gathering? Should it be according to job title or role, or is there mileage in first investigating how things really work before deciding who to interview? There's quite a lot in that, but the key players and what order should you do things? Figure out what's happening and then interview people, or interview people and then figure out what's happening?
you've got to get your foot in the door first, and you've got to get people to see you, which sometimes is a hell of a job in its own right. So I think, and as a qualitative researcher, it's really important to get the trust of people. And again, it depends on the local politics as to which way you've gone into it. Some ways we've gone in from the top, and we've found that there's a lot of distrust on the ground because people think they're being, spied upon. We've had to make contracts with nurse managers and HR to say that we won't report on any behaviour that we see which may be seen as adverse unless it directly threatens patients and so on. And with that, you can get the trust of people on the ground sometimes. It depends on the structure. I'm not that bothered by hierarchy. I just like to get in as close to the ground as possible at the start. But sometimes you've just got to, feed the egos a bit and say, clearly this is your unit and you're the leader of it. And, I really respect this. Anything I should look out for, any tips and hints. It doesn't matter whether you go in at the top or the bottom up at the end of the day, because you've got to get information from both sides and then try and square all that into an account of reality or your view of reality.
Thanks very much for that, Nick. One final question here we're just nearly at the top of the hour. So a question from Pat O'Connor, who is the Director of Research and Development at NHS Tayside. Pat's been keeping the chat very active through your call, Nick. Pat asks, do we need different evaluation models for the context? For example, macro, meso and micro level changes.
Thanks for keeping things going, Pat. I think that's a really good question. We've been trying to work through that ourselves, and we tried to come up with a system based on that, and it didn't really work for me. I think it is having a ragbag of tools, looking at what you're trying to achieve, and that the scale doesn't necessarily matter too much. I think I'd just say, what's the question? What are we trying to achieve? How can we find that information? Sometimes national data is available and so on, but it depends again what's to hand.
Thank you very much for that Nick. We're just coming on to the top of the hour. So Nick, I think you've given us a wonderful journey through what could be a very complex area. We found it very engaging. We love the practical examples, and many of the comments in the chat have kind of spun off into conversations around some practical examples. You've kept it really simple, which has been great for me. We've created, thank you for the resources that you've put forward in the bibliography at the end, and we've, through the chat function, created a whole bunch of related resources also. So that has been fantastic. I'd like to also just a shout out to Donald McGregor from NHS Tayside, to Wendy Copeland-Blair, Head of Performance at NHS Merseyside Care, Leslie White from the Quest team, Shadi Boutros from NHS Tayside, and others, all of whom have contributed to the chat. Nick, it's been a really tremendous session, and I'd like to thank Karen for her questions also. Thank you again, Nick.
It's been a pleasure. Thank you.
Thank you. Now, folks, stay with us. We're just we're coming up to the top of the hour, but just a big shout out for our next speaker. Helen Bevan will be well known to many of you, and Helen is joining us on the 23rd of September, where she's going to be talking to this interesting title of Being a Great Change Agent, How to Rock the Boat and Stay in It. So just a big thank you to everyone involved in running the call today, to Karen, to Carmen Forrest, Jennifer Graham, and to Ross for bringing us all together. We'll be in touch with the link and your certification for your CPD, and we really look forward to seeing you and hearing from you on the 23rd of September. Thank you all very much.